Welcome back, everyone. We do hope that you had a rejuvenating break. We will now move into our third session, the topic immune therapies. It will be chaired by Dr. Tom Martin from the University of California, San Francisco. We'll have 3 presentations for this session, and we'll then be joined by a panel for the discussion. I'll now turn it over to Dr. Tom Martin to open up the topic.
Thanks, Patricia. And thanks, Brian, for inviting me. And Vincent, this has been a great morning. It will prove to be, I'm sure, a great afternoon. We have all been, intently watching the development of these immunotherapies. We're going to have 3 really good talks. And I think each and every meeting that happens for the last few years, we're all surprised to hear what the next agent is that's really doing great in the myeloma relapse and refractory space. So again, we have 3 good talks. So Patricia, why don't we start with the talks?
Great, thank you. Our first presenter is Dr. Saad Usmani from the Levine Cancer Institute, Charlotte, North Carolina. He'll be presenting on update on bispecifics. Dr. Usmani, I will give the floor to you.
Thank you so much, Patricia. All right, so I'm going to start this session off with providing updates on bispecifics in the context of myeloma therapies. These are my disclosures. So we're all familiar with the different kind of antibodies that are used as platforms in hematologic malignancies. The naked bodies generally have nothing attached to them. They can identify a specific surface marker on the cancer cell and engage the immune-mediated mechanisms to do the cell killing. Dr. Lonial will cover the antibody-drug conjugates, where the antibody has a toxic payload attached to it and delivers it to the cancer cell. And I'm covering bispecific antibodies. And the way that the bispecifics work is by recognizing CD3 on the T cell. And one portion of the antibody recognizes a target antigen on the myeloma subsurface. And it's in many ways, could be a poor man's CAR T cell therapy like interaction that these antibodies can initiate. I'm having some trouble moving my slides. Okay, here we go. So bispecific antibodies have many different platforms. This is not a new technology. The bispecifics were originally developed back in the 60s, but didn't make it to the clinic until the 1990s, initially for GBM. But because of high-grade CRS and some patient deaths didn't make it beyond that, it wasn't until the early 2000s when the blinatumomab experience in pediatric ALL led to an expansion of bispecific technology. By that time, steroids and IL-6 directed therapy had made it convenient or better tolerable in clinical trials. But there are many different bispecific platforms that are out there in clinical development in multiple myeloma. I've just shown you a few of these, and what this colorful chart really means is, each of these moieties belong to the variable region of either the heavy chain 1 or 2, or the light chain, a variable region of the light chain 1 and 2. And then the light blue and the dark blue portions represent chimeric portions, so the murine pieces of the immunoglobulin, which can be heavy chain or light chain. And it's the unique structure that represents these different platforms. What they're trying to achieve is the same. So the terminology we use, the duo body or bispecific or BiTE, those are proprietary because of the structure of the antibody, but they are really under the umbrella of the broader category of bispecific antibodies. And we all know that BCMA has been recognized as a selective plasma cell antigen. It's a popular one that has been utilized now in development of CAR T cell therapies, and we'll hear about this a little bit later from Dr. Maduri. But BCMA has been the target for several bispecifics that have been reported so far. The first report was with AMG 420 in relapsed refractory multiple myeloma. Dr. Top has presented these data at ASCO in 2019, and the AMG 420 is based off of the same platform as blinatumomab. So it has a short half-life, and it had to be given as a continuous infusion, posing some logistic challenges. Nevertheless, all of us were excited when we saw these results with originally in the 400 microgram per day dosing, 5 patients reported MRD negativity, and within that dosing cohort, 7 out of 10 patients actually responded. The overall CRS grade was grade 1 and 2 for the patients who did see CRS in this setting. And 13 of the 42 patients who participated in this dose escalation phase 1 study did have responses. So encouraging proof of concept kind of data were reported. We all know from that AMG 420 is not moving forward in clinical development the way that we had expected to. I believe another antibody, AMG 701, is now being moved forward for broader clinical development by Amgen. Then Dr. Costa presented the data on the CC93269 BCMA T-cell engager. Again, this is a bispecific antibody. It's called a T-cell engager because of the structural difference from the duo antibody or the AMG 420. But Dr. Costa had presented the early dose escalation data of this phase 1 on 30 patients, demonstrating that there was a high response rate in that higher cohort of either patients who received the 10 milligram dose or 6 to 10 milligram dose. Almost all patients in that dose cohort had a CRS, but primarily it was grade 1 and grade 2. And then I presented on behalf of the investigators of this particular study, phase 1 study of teclistamab, a humanized B-cell BCMA-directed bispecific antibody at ASCO a couple of months ago. I reported on the dose escalation portion of the IV formulation. Patients had median of 6 prior lines of treatment, and a step-up dosing schema was utilized for doses above 38.4 microgram per kilogram. And the dosing for this drug is on a weekly basis. And what I reported was an overall CRS grading of 1 and 2 in about 60% of the patients. On the higher doses of 270 to 720 microgram per kilogram, the CRS percentage was 62%. And again, all grade 1 and grade 2. And within that cohort of 270 microgram per kilogram, total of 12 patients being treated, I reported an overall response rate of 67%. We saw 4 out of 5 patients who were MRD evaluable having MRD negativity at 10 to the minus 6 in this experience. So currently, there are several other bispecifics in clinical development. As I mentioned, BCMA is a very popular target, so there are at least 6, if not more, bispecifics. I've only put the selected ones here. But then there are other novel targets being explored, GPRC5D with talquetamab, CD38 with AMG 424, GBR1342, and then there's an FCRH5 bispecific antibody in early phase clinical development as well. So just to summarize and end my portion of the talk, there are several bispecific platforms in clinical trials, and there are going to be comparisons drawn to the CAR T-cell therapy because the advantage we have with bispecifics are being off-the-shelf options. The safety profile appears to be better, and there are some that are being now looked at with subcutaneous formulations. Potential disadvantages is the fact that you may have to keep patients on continuous therapy as long as it's working, unlike CAR Ts, which are kind of a one and done, at least for several months in the relapse refractory setting. The BCMA-directed bispecifics are showing impressive safety and efficacy, even though the data is early. But it's highly likely that if we are to look for BCMA-directed immunotherapies, either bispecifics or CAR-Ts, the bispecifics may move into earlier lines of treatment with a bit rather more ease than the CAR-Ts. And then there are novel targets of bispecifics in early clinical trial development, which makes an all immunotherapy-based myeloma therapeutic strategy realistic in clinical investigation in the future. And with that, I will hand things over back to Dr. Martin and Patricia.
Thank you very much, Dr. Usmani. As a reminder to those with questions, after our three speakers, we will have a discussion. Our second presenter will be Dr. Sagar Lonial from Winship Cancer Institute of Emory University, Atlanta, Georgia. He'll be presenting on update on belantamab. Excuse my language there. Dr. Lonial, over to you.
Thank you very much, and I appreciate the opportunity to briefly talk a little bit about belamaf, mostly because it's now a potential treatment option for those of us in the U.S., and from what I understand, it'll likely be approved in Europe as well. So let's get started in terms of mechanism of action. You heard from Saad just a few moments ago that it's an antibody-drug conjugate. The immunoconjugate in this is actually a molecule called MMAF, which is different from MMAE, which is often used in many of these antibody-drug conjugates, particularly in other diseases. And so that MMAF does have some unique adverse events that are associated with it. So the DREAM2 study is what led to the FDA approval, and as you can see, on average, 3 or more prior lines of therapy with belamaf at either 2.5 mg per kg or 3.4 mg per kg, with overall response rate being the primary endpoint, and then all of these secondary endpoints that you see described here. Now, if we look at just the 2.5 mg per kg arm, you'll see the overall response rate was about 31%, and at the initial review of the data, the median DOR with 9-month follow-up had not yet been reached. But if we now look one step further at the 13-month follow-up, the median DOR is now 11 months for the 2.5 mg per kg group. And as I've said all throughout the process in the last few months, to me, DOR in this context really speaks to an amalgamation of efficacy, which is the overall response rate, and safety, which allows you to stay on drug long enough to be able to maintain or further deepen that response. And that's the value of DOR in a refractory myeloma patient population. Remember that the average number of prior lines on this trial was between 6 and 7. So very heavily pretreated group of patients across the board. Now, that translated into improvements in overall survival, and as you'll remember from the Mammoth study in aggregate, the median expected overall survival for these patients is about 9 months. You'll see here that if you achieved an MR or better, the median expected overall survival was far superior to that, again, further supporting the benefit of these patients among those patients who actually did get to a response. Now, I think more importantly, it's important to talk a little bit about this new adverse event. And the reason I'm saying new is for those of us in myeloma, we don't really think about ocular toxicity as being something that we're able to deal with. But certainly many of our colleagues in solid tumor oncology are beginning to deal with other agents that have ocular toxicity as well. So let's talk about keratopathy, because keratopathy is the most common adverse event seen in this. And what it means is microcysts within the cornea. And just as these are not things that you and I are used to seeing on routine exam, these are things that ophthalmologists and optometrists are in fact quite used to seeing, are very easy to look at with a slit lamp exam. And in fact, the objective definitions of keratopathy, grade 1, grade 2, grade 3, or grade 4, are purely ophthalmologic definitions. And they have to involve how much of the microcysts are seen throughout the cornea all around. And so you'll see in terms of aggregate, about 72% of patients had any keratopathy at all. But again, remember, this is purely an ophthalmologic finding. If you start to cut a little bit deeper, what you'll see is that patients who are symptomatic really only form about 56% of those patients, and that patients who have changes in visual acuity only amount to about 18% in aggregate. And I think that this is really important because what it says is that you can have keratopathy in regions of the cornea that don't affect your vision. And it's really changes in visual acuity or symptoms. And symptoms are most commonly dry eyes or itchy eyes, which can be at least mitigated somewhat in part through the use of lubricating eye drops. So again, a slightly different and novel adverse event than what many of us are used to. Now, the best way to deal with these adverse events that do require dose modification or dose holding is actually dose modification or dose holding. And as you can see, what you can see from this in terms of the number of patients that had dose holding, most patients actually deepen or maintain their response criteria during that period of dose holding or dose modification. So unlike other drugs, where when you have to hold the drug, you worry about things getting worse, this does not appear to be the case in this phase 2 experience. The average time to resolution of the ophthalmologic findings of keratopathy are about 70 days. The average time to resolution of the visual changes that are seen is about 22 days. So typically holding for a single cycle is sufficient to allow most patients to begin to resume their treatment. So again, in conclusion, it's a new agent recently approved for treatment of triple-class refractory myeloma. It does represent an off-the-shelf target that is targeting BCMA. Partnership with ophthalmology for dosing is really important to make sure that you're following the ocular toxicity and not allowing patients to potentially get worse, and that you're partnering again with the eye doctor to make sure you've got it under control and that this can be relatively easily managed with dose holding or dose reduction. And with that, I think I'll stop and turn the podium back over.
Thank you. Our third presenter will be Dr. Deepu Maduri from the Tisch Cancer Institute and the Icahn School of Medicine at Mount Sinai, New York. She'll be presenting on review of CAR-T cells trials. Dr. Maduri, over to you.
Thank you, Patricia. And I just wanted to start off by thanking the organizers for inviting me to speak today. And I'm going to be talking about a review of CAR-T cell trials. As you guys all know, myeloma has really changed with the introduction of CAR-T cell therapy because now we're able to offer a one-time treatment to these heavily relapsed refractory patients, and we're seeing deep and durable responses. Given the limited time, I'm only going to focus on these 4 topics today, the BB2121, J&J 4528, the 21217, and the JCAR trial, and talk a little bit about what's in the pipeline next. So the first trial I'm going to start off with is the KARMA study, which is BB2121, now known as ide-cel, and in these patients with relapsed refractory myeloma. So here to the left, you can see the key eligibility requirements. These patients all had to have, good performance status, measurable disease, and they've had to have at least 3 or more prior therapies with a prior IMiD, PI, and an anti-CD38. These patients also had to be refractory to the last line of therapy. And as you can see on the right in the key baseline characteristics, these patients were 100% refractory to their last regimen, and they were 84% triple refractory. These patients were also heavily pretreated. As you can see, the median prior lines of therapy was 6. They had a high tumor burden with 51% of the patients, and 39% of these patients had extramedullary disease. Sorry. Here to the left, you can see the key efficacy data. So for this phase 2 study, the doses ranged for this CAR-T product anywhere from 150 to 450 million CAR-T cells. And the overall response rate, when you looked at all the doses combined, was 73%, with 33% being stringent CR. And however, the 450 dose is going to be the dose that they filed for their label, and you can see the overall response rate was 82% with CR rates of 39%, and their median PFS was 12.1 months. Here to the right, you can see that the most common adverse event for these CAR-T therapies is hematological, and 84% of these patients develop CRS. And what's interesting is that most of the CRS, unlike the lymphoma data, is grade 1 and 2 CRS, with grade 3 or higher CRS being only 5% of the patients. 18% of these patients experience any grade neurotoxicity, with grade 3 or higher being only 4 patients. The KARMA study is fully enrolled, and they actually submitted their BLA for FDA approval, and we're hoping this is going to be the first CAR-T product that's likely available to our patients early first quarter 2021. The next study we're going to talk about is the CARTITUDE study, which is a phase 1b/2 study of J&J 4528, now known as cilta-cel. The key eligibility requirements are pretty similar to the KARMA study we just discussed. The one thing is they did not require the patients to be refractory to their last line of therapy, but as you can see on the right, 97% of the patients were actually refractory to the last line of therapy. These patients were also heavily pretreated. As you can see, 86% of the patients were triple refractory, 28% were penta-refractory, and their median prior lines of therapy was 5, and it ranged anywhere from 3 to 18. 10% of these patients also had extramedullary disease. Here to the left, you can see the key efficacy data. In the phase 1b portion of the study, there were 29 patients, and we saw 100% overall response rate with 86% of the patients in stringent CR. Of the 16 patients who actually went into CR that were evaluable for MRD assessment, we saw 81% of the patients were MRD negative at 10 to the minus 5 or 10 to the minus 6. Given the study has not had enough long-term follow-up, we can tell you a median average follow-up on 9 months was 86%. And here to the right, as you see the key safety data, again, hematological toxicities of grade 3 or higher were quite common. And you can see 93% of the patients developed CRS, with grade 3 or higher being very infrequent at 7%. And 10% of the patients had any neurotoxicity consistent with ICANS, with grade 3 or higher being only 3%. The one thing I wanted to compare and contrast from the KARMA study to the other CAR-Ts is the median time of onset for CRS, which is around 7 days on this study. This study has fully enrolled on the phase 2 portion, and hopefully we'll get data later this year. The next study I wanted to briefly touch base on is the BB2121 study that Dr. Verdeja presented at ASH last year. BB21217 is the same CAR model as the ide-cel, but is actually cultured with PI3 kinase inhibitor, so BB007, to basically enrich these T cells for a memory-like phenotype. This was a very small study for the data that we have currently, and there were 39 patients enrolled on this study, and they were also heavily pretreated with a median 6 prior lines of therapy. And as you can see on the right, the doses also ranged anywhere from 150 to 450, and we actually have very little follow-up on the 450 dose of only 3.3 months at data cutoff, with the most follow-up was 17.6 months for the 150 dose. You can see that 33% of the patients achieved stringent CR, and the median duration of response was 11.1 months for the 150 CAR T-cell cohort dose. Here to the left, you can see, again, mostly the toxicity is CRS, and it was grade 1 and 2, with grade 3 and 4 CRS being very infrequent, and the same thing for neurotoxicity. And then the last study I wanted to touch base on is the JCAR Evolve study that Dr. Melancotti presented at ASCO as an update this year. The key eligibility criteria are also the same as the other CAR-Ts mentioned so far. The one important thing I wanted to point out is they actually do have an arm for a BCMA cohort. So for patients who relapsed after prior anti-BCMA directed therapy, they can enroll on the study, and I know they just started enrolling, so it'll be interesting to see what that is going to show. But to the right, you can see the key baseline characteristics. This, again, was a heavily pretreated population, as the median prior lines was 6. We had 94% triple refractory, 48% penta-refractory, and 23% with extramedullary disease. In terms of the overall response rate, initially it was reported for the 50 milligram dose and the 150 milligram dose, and they had an overall response rate of 79% with CR rates of 43%. But in this study, when Dr. Melancotti presented, they actually only focused on doses from 300, 450, and 600, and the overall response rate was 92% with 36% CR rates. And here to the right, you can see the MRD by dose level, and it was evaluated by next-gen sequencing. And you can see in the 600 milligram dose, they only had 3 patients that were evaluable at that time, but all 3 were 100% MRD negative. This study is expanding into the phase 2 portion with the 600 CAR T-cell dose. In terms of the cytokine release syndrome, 89% of the patients had CRS. Also, again, mostly grade 1 and 2, with very few grade 3 CRS, as well as very few grade 3 or higher neurotoxic events. In terms of the updates on all the CAR Ts, I kind of put it together in a table so it's easier for us to look at. Most of these patients, as we talked about, are heavily pretreated. The doses ranged except for the CARTITUDE study where they had a flat 0.75 million CAR T cell per kilogram of body weight dosing. Most of these patients are heavily pretreated, and the overall response rates ranged anywhere from 82% to 100%, with CR rates of 33 to 86%. We obviously don't have enough long-term follow-up to get the PFS for all the studies, but from what we know, the KARMA study was 12.1, and we're awaiting more data to see the longer-term follow-up for the other studies. To close off, I just wanted to say there are quite a few other CAR T trials in the market right now. The one I wanted to point out was the next generation BCMA CAR T. This is done by Juno using the same JCAR product, but the biggest issue for our CAR T patients is the manufacturing time of anywhere from 5 to 6 weeks. Here, they're going to try to manufacture at a much faster rate. They're saying about 3 weeks. We're to enroll our first patient sometime next month, and so we'll see how that trial will do. And then we also have the GPRC5D CAR T. As you know, all the CAR T so far are heavily saturated with BCMA. And so this one is actually a different target called GPRC5D that's being tested in a bispecific and now also going to be tested in a CAR T. And the next thing is to help with the manufacturing time, we also have the AlloCAR, which is an off-the-shelf CAR, where we have these rapidly progressing patients who may not make it to CAR T because they don't have the 5 to 6 weeks to wait. But here we're hoping with off-the-shelf CAR, these patients can be helped very quickly. That's all I have for my presentation. I'm going to turn it back to you, Patricia.
Thanks very much, Dr. Midori. I'll now introduce you to our panel for the discussion on this session, Immune Therapies. Dr. Jesus Verdeja from the Sarah Cannon Research Institute, Nashville, Tennessee, Dr. Yi Lin from the Mayo Clinic, Rochester, Minnesota, and Dr. Adam Cohen from the University of Pennsylvania, Philadelphia. We'll also be joined by our session chair, Dr. Tom Martin, and we'll welcome back our speakers when there's a question for them to respond to. We will have some polling questions for this section, but before we get to those, Dr. Martin, did you want to address the panel for initial questions and feedback?
Thanks, Patricia. And thanks for the speakers. That was a wonderful session. We're obviously entering a new era now where we're starting to get approvals of some of these novel agents. So maybe I'll ask Dr. Loniel to come back for a second and ask the panel, so soon we're going to have approval of belantamab. This is going to be really our first drug for triple class refractory, specifically as a single agent. Should that be our first drug for triple class refractory myeloma? And is there anybody who you would not give this drug to? Is there any reason not to give it to some patient?
Thanks, Tom. I think that's an important question. At least in my view, I think certainly this is a pretty reasonable treatment approach to give to somebody with triple class refractory myeloma. And so it is my go-to. I think the subset where I might have some limitation are patients that already have significant underlying corneal defects or problems at the very outset. But outside of that, I think it's a pretty easy treatment to tolerate from our perspective as hematologists. There's some thrombocytopenia, a little bit of cytopenias, but really it's a relatively easy drug to give with visits every 3 weeks to the infusion center. So yeah, I think it does rise pretty high in terms of early use.
Thanks, Dr. Loniel. And for the panel, I have a question for the panel. Would anybody on the panel not use this therapeutic because it may affect the response to other BCMA targeted agents? Would anybody not give it because of that reason? Well, let's stick with Dr. Usmani, Dr. Midori, and Dr. Loniel. What do you guys think? Would anybody not give it because of the other therapeutics?
So, I mean, I think that if we had a really young patient who's heavily pretreated, I would prefer to take that patient to CAR T. rather than belantamab at this point. But I think, like Dr. Loniel said, I think it's a good drug that we can probably give for our patients who are heavily pretreated. But we should think about patients who have comorbidities, who can't do CAR T, maybe have too much CRS, they can't handle the toxicity. Then I would reserve, either bispecifics or ADC for them. And for those younger, healthier, fit patients, I would prefer to do CAR T if I can.
So Tom,
Great.
I echo what Deepu has already said. I think the question is, it's not whether we're going to use it. I think it's going to be the choice of the patient, right? So the kind of patients we pick for that therapy, and if there's a CAR T option available for a younger patient, I think that would be preferable. The pace with which the disease is relapsing is going to be important because for CAR Ts you have to hold the disease back for 6 to 8 weeks while you're waiting for the product to get back. And so, if for our triple class refractory patients who truly have no other options, instead of rehashing the prior therapies and hoping that something will work, I think trying, a BCMA-directed strategy that's already there, it's off the shelf, you can use it. I think many of us will go for that kind of an option.
I would argue even for many of those younger patients that were being referred to, they're going to need something for that 6 weeks between when you want to give the CAR and when you can give the CAR. And if they get a good response with belamaf, you could sort of ride that out for a little bit and then give the CAR when you have less disease burden. So there's no reason to think that it won't necessarily work later on. So I think there's a way to because it is, as Saad suggested, off the shelf, that does have some advantages to me over things like DCEP, which is what many of us are stuck using when we want to give a CAR and we have that 6-week window where we got to do something in between.
And potentially it's not having any toxicity on the immune environment, versus some of the other ones. So Dr. Usmani, I got a question for you. So you called the bispecifics the poor man's CAR T. Do you really think that? Do you think that the bispecifics may actually, in fact, because it's off the shelf, rise above the CAR T or be in the same kind of level of the CAR T? What do you think? And how should we distribute these therapeutics?
No, I think it's simple logistics, right? So you have to, unless you have the capability of making point of care products within a few days. I think if you're thinking about a BCMA and directed strategy that gets you 70 or 80% response rate, it may not be the 100% that the J&J product is showing, but it's 70 to 80% response rate. If that really bears out in our dose expansion cohorts and phase 2s and subsequent studies, then yes, bispecifics will give CAR Ts a run for the money. I mean, it's going to be a really good option.
It looks like we have some questions from the wall. Patricia, you want to call on some people from the wall?
Yeah, sure. Let's go to screen number 8, and we have Dr. Paul Richardson. Go ahead, doctor.
Yeah, no, thank you very much, Patricia. I really just had a point to build on. I so agree with Sagar's point that belantamab has the advantage of a kind of off-the-shelf platform, and I love the way you frame that, Sagar, around how we can use it. I think certainly what we're doing now in our practice is we're learning from DREAM6, and we're trying to add Velcade because usually insurers are not pushing back against that. It's a cheap option. And I do want to emphasize in our experience how spreading out the dosing of belantamab is very important because this keratopathy, unfortunately, is a challenge. And one thing we've done, and I would love, Sagar, any comments you have on this, we've been keeping our infusions to 60 minutes. We've not been shortening them because we're worried about this potential Cmax effects on the keratopathy. And honestly, we've also been quite conservative about our pre-medication. We've been using hydration. We've been using low doses of steroid because the label is saying you don't have to use steroid, but just being a bit more conservative about that. But I wondered, Sagar, if you have any comments on that, because the keratopathy is a little scary to people if they've not been dealing with it.
Yeah, I mean, I think, Paul, we've been doing probably something similar to what you're describing. When we learned that the steroid eye drops don't seem to mitigate the keratopathy at all, we actually began to switch to vasoconstrictors to see whether if you could reduce exposure to the cornea during the infusion and for the first day afterwards, that would have an impact. It's too early to know whether that's making an impact or not, but certainly local therapy probably makes sense. And one of the things, what explains the high incidence of keratopathy with low incidence of changes in visual acuity is the location. When you develop keratopathy, it typically starts at the periphery and works its way central over the pupil, and recovery is the exact opposite. So I think that explains why you may have ophthalmologic findings that don't have clinical significance. And balancing those two, I think, is the challenge.
Yep, agreed.
Great. Let's go to screen number 36 and Dr. Joseph McHale. Go ahead, doctor.
Great, thanks. Actually, it's a sort of a perfect follow-up question to what Paul just asked Sagar. Sagar, I've been reviewing that data for a while and thinking a lot about what you shared, which was that even when those patients had their dose delays, that they maintained their response. So my question to you about that is twofold. One, why do you think that is unique to belantamab, that despite the fact that these patients are having their drug held due to keratopathy, that they've maintained that response for as long as they have? And then secondly, sort of fitting with what Paul just asked, do you think then that if in that total time frame they were given, X number of infusions at the start, is this speaking to the fact that maybe we should be giving the drug less frequently instead of every 3 weeks, every 6 weeks? If it is a buildup of these blebs, as you described, in the cornea, would it make more sense with time that we would consider giving belantamab less frequently so that there isn't, I appreciate what Paul said about the Cmax in the 1 hour infusion, but could it actually be the almost bortezomib-like, give it once weekly instead of twice weekly, we saw less neuropathy? Should we be thinking about that? So those are the two questions for you, my friend. Thanks.
Yeah, so I think in terms of the reason, my guess is probably, first of all, the novelty of the target. So BCMA is a novel target, and so there aren't many other things the patient has seen that go after it. And the second is the half-life. The half-life is long enough that you're probably seeing that durable effect even beyond just the 3-week interval for dosing. I think that in combination, changing the dose and schedule makes a lot of sense, and I suspect that when we're talking about, for instance, RVD plus Bela or other combinations that are going forward, we'll begin to do just what you described, which is look at alternative schedules for the treatment to try and reduce the buildup or the keratopathy issues, but still maintain the novelty of that target overall.
Thank you.
I think that the jury is really out on whether it's a C max or whether it's a C trough. That's the issue. And so if you lengthen it out, the C trough is going to go down. That might actually be more important. That said, so we have a couple polling questions. Patricia, can we go to the polling questions?
Yes, our first one. Do you see all the categories of immune therapies having a niche? Yes or no? Give it a minute. Okay, Dr. Martin, I'll let you read the results, and then we'll move on to our second question.
Oh, okay, so the preponderance of the data is for the 94% of yes, and thankfully, if it was the opposite, I would turn everybody over to the CLL session next door. Okay, the next question.
All right, next question is, do we need IMWG guidelines for CAR T CRS toxicity grading and management? Yes or no? I'll let you address those answers, Dr. Martin.
Well, that's great, actually. So we have 2/3 saying, yes, we need some guidelines, and another third that says, no, we don't need them. So, Patricia, can we bring in the panel? Because I'm going to ask them a question about this.
Yeah, sure. Go ahead. There's the panel.
All right, panel. So you saw the question. So I guess my question to you guys is, number one, do you think with all these products, our management of CRS and neurotoxicity is relatively similar with all these different products? Do we need a product-specific guideline? Or really, should we come up with a guideline that's going to deal with myeloma patients and how they're experiencing CRS, no matter what the product is, or neurotoxicity? So, Dr. Lin, why don't you start?
Sure. I had responded that I think we need the management guideline. The question is grading and guideline, and I'll just clarify that there's already been a lot of work done with the lymphoma and leukemia folks trying to have some consistency in how we describe toxicities so that we can make some fair comparisons across product and maybe even across diseases. And I don't think we would want to undo that work. So I would recommend that we actually follow the ASTCT/EBMT recommended grading guidelines when it comes to CRS and neurotoxicity. The limitations for those guidelines, though, was that in an attempt to try to come to some consistency in describing the toxicity, is that there are many aspects of the toxicity that for various reasons, whether there could be some subjectivities or the historical differences in management that would be difficult to tease out, are left out from a grading perspective. That would be important for management. And so I do believe thus far from the data that we've seen in our myeloma patient, particularly also coming in heavily pretreated, there are some aspects of management that I think this group of experts could add to. I think something else that's also important, though, is we have two trials that have already completed accrual. One BLA already submitted, another one BLA is anticipated. This is the time that they will be negotiating, if you will, with the FDA what the REMS looks like. And when these become commercially available, the management for CRS neurotoxicities for regulatory requirements will need to adhere to REMS. And so it would be important, I think there would be some role for this group of experts to also be in discussion with both the companies and FDA in terms of how important, are there things that can be common? How granular does the REMS really need to be for product-specific management and potential implications for safety to adhere to these REMS for practices? Maybe I'll stop here and let the other experts also add in.
Thank you. Dr. Burdeja, what do you think?
So I completely agree with you in terms of the CRS grading. I think that needs to stay sort of constant throughout the diseases. But I do agree that the management, I think we have a lot to add to. I think, especially in myeloma, the products are behaving very differently. And so oftentimes, one of the examples would be a patient that has early cytokine release syndrome is defined as someone has cytokine release within 72 hours of infusion. Well, that's every patient on ide-cel. Whereas that would actually be an early CRS for someone on cilta-cel. So I think those nuances are important, and I think we're in a position to potentially help guide that. And then one would argue specifically, whether we should be much more aggressive. I think the current guidelines tend to be a little more sort of kind of conservative in that sense. And I think we have the benefit of having come in later, so we've learned a lot from the past. And so perhaps even the idea of early CRS can be even removed completely, and every patient who has CRS could be treated and use that almost like a litmus test to see which patients may require further therapy or more aggressive management.
And Dr. Cohen, maybe you can briefly address neurotox. Should we have a guideline, a myeloma guideline for neurotox?
So I tend to agree with my colleagues that I think the grading is already been well established, and we shouldn't differ from the other groups. In terms of whether we need really myeloma-specific guidelines, I'm a little bit on the fence here. I think we're waiting to see the ASTCT guidelines coming out. SITC is going to have their own set of guidelines, and there's a little bit of risk if you have too many management guidelines. It's going to lead to confusion, particularly among clinicians who are not just treating one disease. So for me, I guess I'd like to see a little bit more in terms of the guidelines that are going to be coming out from the other groups, get a little bit more data from larger phase 2 experiences in the myeloma trials, and really see how different it is from management from the other CAR T-cell products. Clearly, our risk of neurotoxicity seems to be less with BCMA-directed therapies, particularly the risk of severe neurotoxicity. but I think it remains to be seen whether we really should manage these patients differently if they do develop neurotox.
Great. So, Patricia, let's go back to the wall. I think Dr. Mateos and Dr. Shaw had questions. Maybe we can do one, Dr. Mateos first and then Dr. Shaw.
Sure. I'm trying to locate where Dr. Mateos, there you are. And I also, at this time, we'd like to bring up that if you have not asked a question yet, we would also love to hear from some of you that have not had a chance to speak yet. So please jump on board if you do have a question. So let's go to screen number 7, Dr. Mateos. Did you have a question? No, she's paused herself. So let's...
Oh, we can go to Dr. Shaw while she's getting back on.
Let's go to Dr. Shaw. Let me trying to find out where, is that Nina? And yes, screen 38. Dr. Shaw, go ahead.
Yeah, I was just wondering what you guys see as the biggest challenge of getting the CAR Ts set up at our institutions now. So getting ready for them to be FDA approved and what's going to happen with the workflow. And what do you guys see each of your institutions as the biggest challenge?
Dr. Lin, you want to start?
One of the things that we have commonly heard from various CAR T treatment centers is the coordination of access for leukapheresis and management of patients clinically to get them to CAR T dosing. And I think, in the current year, also managing that with COVID practices, safety in terms of safety, access to centers and so on. And I think we'll need to see how that evolves as the management of COVID also changes over time. That may, in this particular era, poses additional challenges compared to, say, your other off-the-shelf therapies that could be more readily given in the more oncology clinics rather than specialized treatment centers.
Okay, how about you, Adam? We hear at Penn that the escalator on the left goes to CAR Ts and on the right is everything else. Is that right?
Exactly. But I was going to echo what you said. I think, honestly, other than the clinical management of these patients, which keeping them stable for 4 to 6 weeks is always a challenge, the other big challenge is logistics. It's competing with regular stem cell collection, with all the patients collecting T cells for the lymphoma and leukemia products. And now we're going to have myeloma all fighting for that same apheresis machine and then fighting to get a bed once they're admitted. And so these are the things I think really need to be discussed within each institution, and really making sure that the staffing is really being leveled up to be able to have enough space to manage all these patients. Because I think there's really going to be a glut of patients initially once the first BCMA products are approved. And trying to just balance that with all the other services, trying to get their patients CAR T cells and stem cell collection is going to be a big one.
Yep. How about Dr. Mateos? Is she back up?
Yes, in screen number 7, Dr. Mateos, did you have something to add?
No, the only question that you said was in and because I did pray.
Unfortunately, we cannot distinguish your audio right now. It's sounding that it's just not. We can't understand it. I'm sorry. Just check your audio, and we'll come back to you. Let's see. We have Dr. San Miguel with his hand raised.
Yep. Can't hear you.
We can't hear you. Can you test your audio as well? Nope, still not. How about Dr. Dury? Why don't we go to you while we're figuring out some of these audio issues?
So Tom, I just wanted to give you a question off of the chat box. There's an interesting question. Sonia Zwigman asks, has eye cooling been used or evaluated to look at the effect on corneal lesions with the belantamab? Maybe Sagar knows about that. Has that been looked at all?
Yeah, thanks, Brian. I think that's a good question. It's been looked at sort of anecdotally. I don't know that we have formal randomized data like we do for the steroid eye drops, but it's a minimal side effect or toxicity-based approach. And so I think it's a reasonable thing to do, almost along the same line as the vasoconstrictors that you give or that we're trying to give during the infusion as well.
Yes, it's similar to what we used to do for adriamycin with scalp cooling, restricting the distribution of the drug.
Right.
So, yeah, thank you. That's all I wanted to do, Tom, is to interject from the chat box.
Okay,
All
that's
right.
perfect.
Let's see if we could go back and try some audio again in screen number 7. Dr. Mateos, would you like to try to speak again? Let's see how your audio sounds. No. All right. Let's see. Is there anyone else that has not spoken as of yet that would like to add to the conversation? Please don't be shy. Raise your hand with your raise your hand icon. We'd love to hear from you.
Maybe Dr. San Miguel.
Yeah, Dr. San Miguel, let's try your audio again in screen number 6. Give us 1 second to get you on air there. Try again.
Can you hear me now?
Yes, go ahead.
Okay. If a patient has failed a bispecific, what is the expected efficacy of the CAR T, BCMA? I'm talking about BCMA, and the other way around. Patient that has relapsed after CAR T, would you treat with BCMA bispecific?
That's a great question. So, Patricia, can we bring up the panel?
Yes,
So
there you go.
sequencing is the big issue now. So what do you guys think? Dr. Maduri, what do you think about sequencing?
I mean, I think that's a question that we really need more data on to answer, right? Because I know with the JCAR study, they're actually allowing an arm where you've had prior BCMA therapy, and if you failed a bispecific, you can go onto this CAR T and see what your response is. And also for prior CAR T, they also allow prior BCMA failure CAR T. And then the same thing with the CAR-T2, they all have an arm. I think we've had sequenced bispecifics and CAR Ts here at Sinai, but usually our bispecifics were GPRC. We haven't sequenced a BCMA bispecific followed BCMA CAR because all the clinical trials exclude one another for a majority of the thing. So I think it's an important question, and I think we'll get more real-world evidence data once the CAR T is approved and now the belantamab is approved, and we're going to see more patients go on it readily. Time will tell.
So Amrita Krishnan has another question for you, Dr. Maduri, and that is, well, when we have more than one BCMA CAR T approved, then how do you choose? We'll ask you, and then Dr. Lin, you can answer after that.
Yeah, I think it's all going to come down to PFS. If I have to look at these patients, because the toxicity is pretty similar to all these CAR Ts, right? It's mostly grade 1 and 2. Neurotoxicity is quite rare. So it'll come down to PFS. If you have one product with PFS 12 months, 18 months, you may have to pick and choose based on that. It could be that other than that, I don't know what other big thing I would choose, because toxicity is not a big issue. It's just a manufacturing time. I guess if there's off the shelf and you have a patient who's rapidly progressing and can't wait, then you'd want to choose that. But if you have one that's manufacturing 5 weeks, one that's manufacturing in 2 weeks, that's another reason why you would pick one over the other.
Dr. Lin?
I would agree with everything that Dr. Maduri had said, and I would add for the more immediate BCMA CAR T that we're anticipating coming to the market, reimbursement and payment can play into factor. Based on just right now, we don't have enough follow-up necessarily to say one PFS is superior than the other, or any specific concern from toxicity logistics standpoint. Then the timing to first symptom of CRS, for which the patient may need inpatient management, can become a factor. So at Mayo, and I know there are a number of centers in the US that do outpatient CAR T, and that can have a positive financial impact when it comes to payment, particularly on government patient, which would be a significant proportion of our myeloma patient population. Then it can become financially more attractive to be able to treat patients outpatient longer before they need to be admitted inpatient. So then it may end up coming down to that for a commercial CAR T.
So I have a question for the panel, and that is, in the relapse refractory setting, these are probably the most effective therapeutics we've ever seen, right? the bispecifics and the CAR Ts. So we have a variety of different spaces where they can go. Smoldering myeloma upfront as part of newly diagnosed myeloma, early relapse. Where should these drugs be placed next? Where should the development go for these therapeutics? Dr. Verdeja, you want to take that one?
Yeah, no, I mean, I think any of those are a possibility. I think it's going to come down to the toxicity, right? So, unfortunately, there are some, bad toxicities that can occur, and patients have died on these therapies. So, I think we need to kind of take that with a little bit of a grain of salt if you're going to give it to a smoldering patient, for example. But I think we're starting slowly. So I think the high risk patient population, the upfront trials looking at the population, I think are perfect. I think we'll get a good idea of efficacy and duration, and also safety at that point. And then I think, yes, I think if that is borne out, I think we should be moving it much earlier, even into the smoldering phase at some point, or the bispecific, or some kind of immunotherapy instead of chemotherapy, I think.
Dr. Cohen?
And I would agree. I think really this toxicity seems to be less when patients have better disease control and less burden, at least perhaps in the early studies. So you could start to think about this as a consolidation strategy. And as we talked about even in one of the prior sessions, for patients with high risk cytogenetics or other features that have not achieved a deep remission after initial therapy, that might be a great time to come in with a CAR T cell or one of these other options. And try to mop up that residual disease that's otherwise resistant to the standard therapies. So I think those are the trials that we really need to do next.
A tremendous session with lots of really good discussion, but all good things have got to finish at some point. And so it's time for some closing comments, okay?
So yes, thank you very much for the panelists. Thank you very much for all the speakers. It was a great session. I actually think that we all are anticipating every meeting again going forward that we're going to see something else that's amazing coming out of these new novel therapeutics, and it's going to really change the way we treat myeloma, and it's going to be really fun over the next 5 years seeing where we actually sequence all these different agents. And I'll just put in a plug that we would like to do a global database of BCMA, starting with BCMA therapeutics, so that everybody can be involved in this and we can see about sequencing and ordering, and we'll give you a report out from the immune working group tomorrow. So thanks everybody for participating, and looking forward for the next session.
Terrific, thank you. And we will now move into our fourth session, the topic relapsed myeloma. It will be chaired by Dr. Joseph McHale of Translational Genomics Research Institute, City of Hope Cancer Center, Phoenix, Arizona. We'll have two presentations for this session, and we'll then be joined by the panel for discussion. So I will now turn it over to Dr. Joseph McHale to open up this topic.
Great. Thanks so much, Patricia. And of course, it's great to be with everyone today. I know it's been a long day for many of you, and it's late for some of you, still not even lunchtime for some of us. But let's hold on strong for this session. We obviously just had some amazing discussion around immune therapies, led by Tim, as I call him now, instead of Tom. That would be Tom Immune Therapy Martin. So we're going to now think a little bit more about relapse disease, and in particular, primarily in two bits, initially the earlier relapse and then later relapse. And as Patricia mentioned, we have two excellent speakers followed by quite an impressive panel. So Patricia, I'll turn it back to you to introduce our first speaker.
Thank you. Our first presenter is Dr. Thanos Dimopoulos from the University of Athens. His presentation on how do we incorporate new drugs for relapse disease was pre-recorded as he was unable to attend today's session. We will now view the presentation from Dr. Dimopoulos.
Hello, I'm Thanos Dimopoulos from the National and Kapodistrian University of Athens, and I will share with you new data on how to incorporate new drugs for relapsed or refractory multiple myeloma. Current treatment strategies in multiple myeloma include induction for both transplant eligible and transplant ineligible patients In younger patients, induction is followed by 1 or 2 autologous stem cell transplants to support high-dose melphalan. And then typically the patients receive immunomodulatory agents as maintenance, namely lenalidomide. For older patients, induction is used for a longer period of time than in younger patients, and then patients move again to lenalidomide maintenance. Although an increasing number of patients may remain without evidence of progressive disease for many years, unfortunately, so far, most of the patients will experience disease progression. What do we know so far from phase 3 studies in relapsed and refractory multiple myeloma? We know that 3 drugs combinations is better than 2 drugs. We know that continuous therapy has a better outcome than fixed duration therapy. We know also that there are drugs in the same class of agents that may have more activity than others. For example, in the relapse setting, we know that calfizomib is more active than bortezomib, and also that pomalidomide can induce responses in some patients who are resistant to lenalidomide. Also, we know that adding drugs with new mechanisms of action may improve outcome and overcome class resistance. The sequence of different drugs may be important, such as class switch that may be of significant benefit. Let's see now some recent studies. And here we see studies that included patients who were anti-CD38 naive. Most of the patients were lenalidomide pretreated. Several patients were lenalidomide refractory. And you can see here the CANDOR study and the IKEMA study. In the CANDOR study, patients were randomized to receive either calfizomib and dexamethasone at a dose of 56 milligram on 2 consecutive days, or the same regimen with daratumumab. And you can appreciate that there is an improvement of PFS in favor of DARA-KD with a hazard ratio of 0.63. The IKEMA study had a similar design, but instead of daratumumab, isatuximab was used. And again, in the initial presentation of the study, there was a benefit from ISA-KD with a hazard ratio of 0.531. Lenalidomide refractory patients is becoming a significant problem, and you can see that with older studies such as CASTOR, with DARA-VD, median PFS for these patients was 7.8 months. However, with the addition of daratumumab or isatuximab in the combination of calfizomib and dexamethasone, we have a significant improvement in the PFS for this particular subset of patients who progress on lenalidomide maintenance. For this particular patient population, there are other combinations that have been evaluated, such as with anti-CD38 monoclonal antibodies in combination with pomalidomide and dexamethasone. And so far, we have data on the ICARIA study, which combined isatuximab with pomalidomide and dexamethasone. And you can see here better outcomes as compared to pomalidomide dexamethasone. And also we have phase 2 and randomized phase 2 studies with daratumumab and pomalidomide dexamethasone, which again shows a benefit in this subset of patients. Another type of regimens include combinations with monoclonal antibodies, again targeting lenalidomide pretreated or refractory patients. And we have a combination of selinexor with daratumumab and dexamethasone. which shows here a high response rate at 73% and the PFS at 12.5 months. And also we have combinations of venetoclax, daratumumab, and dexamethasone, which again shows a very high response rate. Now, there are patients who are not only refractory to lenalidomide, but also they may progress on anti-CD38 treatment. Potential combinations for these particular patients may include the elotuzumab, pomalidomide, and dexamethasone combination, which in the context of ELECANT-3 trial showed a significant improvement of PFS. And also the very recently approved anti-BCMA, antibody drug conjugate, belantamab mafodotin, which again shows a significant PFS in these hard-to-treat patients where almost all patients were also previously exposed to daratumumab. And this is the results, the preliminary results of DREAM-6 study, where belamaf is combined with bortezomib and dexamethasone. Other combinations that could address patients who progress on lenalidomide and anti-CD38 monoclonal antibody is the selinexor bortezomib dexamethasone combination in the Boston trial, which was recently presented. And as you can see here, the SVD combination is associated with a median PFS of 14 months. And also the venetoclax VD combination, especially in patients with 11-14, that has been also associated with a significant improvement of PFS as compared to control. Other combinations without monoclonal antibodies targeting again this particular patient population could be the combination of venetoclax with calfizomib and dexamethasone, recently reported, and you can see high response rate, especially in patients with 11-14 translocation, and also another interesting new agent, melflufen, which has been administered in the context of phase 2 study in patients who are refractory to daratumumab and pomalidomide, and overall there is a median PFS of 4 months. Combinations without monoclonal antibody for lenalidomide refractory patients. We have the pomalidomide bortezomib and dexamethasone combination for patients who have been exposed to lenalidomide, and many of these patients were also resistant. And also we have the calfizomib, pomalidomide, dexamethasone for lenalidomide refractory patients. Again, significant activity with a median PFS of 10.3 months. New drugs, we have the CELMoDs, for example, the compound CC92480 with dexamethasone in heavily pretreated patients, many of those exposed to anti-CD38 with significant activity in about 30% of the patients, and also the role of selinexor with dexamethasone in the context of STORM trial with responses again in approximately 1/3 of the patients. To conclude, refractoriness to lenalidomide after first-line treatment and to anti-CD38 after 1 or 2 lines of therapy is one of the most pressing emerging clinical scenarios that we need to address. Switching drug classes and non-cross-resistant combination may be the most effective strategy. Yet we don't have a lot of data for daratumumab refractory patients, but there are several combinations, as I showed, that are emerging with activity in this disease. And we need to better understand the mechanism of anti-CD38 resistance and to develop more targeted studies in double lenalidomide and anti-CD38 refractory patients. Thank you very much for your attention.
We thank Dr. Dimopoulos for sharing his presentation with us. As a reminder to those questions, after our presentations, we will have a discussion. Our second presenter will be Dr. Philippe Moreau from Nantes University Hospital, Nantes, France. He will be presenting on IMWG guideline for relapsed myeloma. Dr. Moreau, over to you. We can't hear you. Could you please check your audio, Dr. Moreau?
Me now? Yes?
Yes, we've got you now. Thank you. Please start again.
Yeah.
Thank you.
Thank you. So I wanted to share with you some data that we discussed. In fact, currently we are trying to write a manuscript on these recommendations for the treatment of relapsed myeloma. And that's not a very easy task, in fact, as you understood from the presentation of Thanos, with many, many trials, in fact, addressing the best combination, the role of the best combination in the relapse setting. In fact, we know that the choice of the treatment at the time of the first relapse is related to the frontline treatment. And this is a summary of what Vincent previously discussed. You see that we are selecting treatments according to transplant eligibility in many countries worldwide, and we are using VRD for elderly patients, or DRD when the combination is available, and we can also use in some countries Lendex or VMP. For patients that are eligible for stem cell transplantation, obviously VRD is standard of care, but we are going to use more and more quadruplet combinations, including CD38 antibodies, followed by stem cell transplantation and LEN maintenance in the majority of the cases. So when we want to treat patients at the time of the first relapse, and Thanos alluded to this very important issue, we have plenty of options now, and I just put here the list of phase 3 trials looking at progression-free survival as a primary endpoint, and you are knowing very well those data with Lendex as a backbone, with PI either VD or KD plus third agent as and PI-based combinations, but we also have now Pomdex as a backbone, and we are awaiting probably at the next ASH meeting for PD daratumumab to be released. So we have here at least 12 trials showing that triplet combinations are probably the best options available, and for 3 of them, we already have overall survival benefit. So how to select the best option? And Thanos clearly mentioned that now more and more we have patients that will progress on lenalidomide, and this is the frontline treatment with Lendex until progression, or DRD until progression, or LEN maintenance after stem cell transplantation. So how I treat a patient that is progressing on lenalidomide, this is not that simple, in fact, because this subgroup of patients is difficult to treat, obviously subgroup of cases. So the preferred options that we did discuss, and I would like to thank many of you for reviewing the paper that did circulate recently. We have phase 3 trials showing definitely better progression-free survival. We have this DARA-KD based on Condor, recently published. We also have the IKEMA study showing that ISA-KD is a good option. And Paul reported the Activism study that is, and POMVD is also approved for patients progressing on lenalidomide, not only in the US, but also in Europe. We also have second options based on phase 3 trials, such as VD-DARA or KD, based on Endeavor, but we know that the median PFS is less than 1 year for DARA, VD, or KD when patients are progressing on frontline lenalidomide. We will soon have phase 3 data from Apollo, and we know that patients at the time of the first relapse progressing on LEN could be included into this prospective comparison of PD versus PD DARA. So definitely we need to see those data to put them into a preferred option possibility for sure. But we know also that in some countries, DARA or isatuximab is not yet available. That's true as well for carfilzomib, for POM. So definitely we have to look at other combinations that are potentially less effective, but that will help in the treatment of our patients, such as VCD, for example. And we did discuss into this manuscript about those possibilities when drugs are not available. So this is the first option when patients are refractory to lenalidomide, but we also have patients that are going to progress when the disease is not refractory to len. So in this setting, in fact, the preferred option based on phase 3 trials are DRD, Lendex daratumumab, based on Pollux, with outstanding progression-free survival, a benefit in terms of PFS2 as well. We don't yet have overall survival benefit, but based on the hazard ratio, we can expect with a longer follow-up an OS benefit. KRD is also a good option when DARA is not available. We here have a list of second options based on phase 3 trials with 1B recommendation level. And when, again, DARA or Carfil are not available, we can use Lendex in this situation as a backbone, in fact, or VD or VCD, again, that may help physicians in some countries. So this is the summary of first relapse when patients are not refractory to LEN with the preferred options and with other options that can be available. And this is the summary of the proposals that we did discuss, all of us, at the time of the first relapse. Thanos clearly mentioned that we will have now more and more patients progressing on DARA-based combinations frontline, and we know that VMP-DARA is approved, not used very frequently in the US, but frequently used in Europe. DRD, based on Maya, will be used as soon as reimbursed in many countries. This combination is approved. And we know as well that for young patients in the setting of stem cell transplantation, VTD or VRD DARA, followed by DARA maintenance, will be used as well based on Cassiope, Griffin, and soon Perseus. So what to do when patients are progressing on with VMP DARA? The logical options is to use Lendex as a backbone, and we know that we cannot use at the time of the progression a CD38 antibody. So KRD is a valid option, ixazomib Lendex as well, or ELO Lendex potentially. When patients are progressing following DRD, we know that we can switch from LEN to a proteasome inhibitor, and we can use either carfilzomib or bortezomib. And those are the options that we can propose to those patients, although we have very, very few data available on patients progressing following DRD. When patients have received 2 or more prior lines of treatment, Thanos previously discussed important data, and here are the proposals that we can recommend within the International Myeloma Working Group. The preferred options are the following: any first relapse options that have not been tried. We can use, based on phase 3 data, KD DARA or isatuximab KD as well, IKEMA and Candor. We can also use PD as a backbone, and we know that PD DARA, based on phase 2 data, is a very promising combination. We are awaiting for Apollo with PD DARA for sure. LOPD based on the phase 2 Eloquent study, or KPD based on phase 2 as well. We don't have any phase 3 data with PD-ELO or KPD yet available. And when DARA, when Carfil or ELO are not available, PD based on this old MMO3 study is the backbone, and maybe we can increase the efficacy of Pomdex with the addition of cyclophosphamide into the PCD combination. So additional options that are already available in some countries. Selinexor is approved in this setting. We can add panobinostat to bortezomib based on the Panorama study, or we can use more conventional combinations of, let's say, old drugs. We know that BCMA targeting agents are available or will be available very soon, and we discussed in the previous session about the role of belamaf, the role of BB2121, and for sure venetoclax will be also proposed in many patients with translocation 1114 or BCL2 high expression. So this slide is summarizing the proposals for advanced patients. And well, I would like to have now your opinion on those proposals from the International Myeloma Working Group. And you understand clearly again, that's a very difficult task to summarize into some tables, some figures, and into a single manuscript, all the options that are available now worldwide. Thank you.
I'll introduce you to our panel for the discussion on this session, Relapsed Myeloma. Dr. Francesca Gay from the University of Torino in Italy, Dr. Niels van de Donk from VU University Medical Center in Amsterdam, the Netherlands, Dr. Nina Shah from the University of California, San Francisco, and Dr. Nupur Raji from the Center for Multiple Myeloma in the Mass General Cancer Center, Boston, Massachusetts. We will also be joined by our session chair, Dr. Joseph McHale. And we'll welcome back our speakers when there is a question for them to respond to. And we do have some polling questions for this section. So Dr. McHale, why don't you start us off with some opening comments and some polling questions?
Great. Thanks so much, Patricia. And thank you to our speakers. Sorry that Thanos is not able to be with us in person. Philippe, I think you deserve a special award just for trying to herd all the cats together of all of us involved in those guidelines. You put 20 myeloma doctors in a room and you have 30 opinions. So kudos to you to try and rally us together into a single manuscript. And that was a really excellent summary of what we have discussed. I think, Patricia, now would be a very good time for us to actually go right into the questions, because I think these two questions that we've created will indeed set the stage for the discussion. Up until now, a lot of your questions have been yes, no. These ones are going to require a little bit more thought because we've given you options of answers. So why don't we move to our first question, and then I'll be able to speak to our panel. So I know we have lots of different countries represented and access to the therapies. So I want you to assume that you have access to all therapies in a patient who is initially treated with a VRD plus or minus transplant. So whether or not they were transplant eligible or not, let's assume they received VRD and then went on to lenalidomide maintenance, and they're now relapsing. So what would be your ideal combination right now to use for that patient? Would it be daratumumab pomalidomide dex, daratumumab carfilzomib dex, isatuximab pomalidomide dex, or isatuximab carfilzomib dex? And we'll give you a moment to look at this as you answer. So later on, Philippe, I'll get you to maybe comment on this and some of our panel members, but it's interesting that, as you mentioned, we don't have phase 3 data yet for DPD, but right now it is actually the most commonly used first relapse therapy in the US. Obviously, isatuximab has just been approved, and isatuximab Cardex is not yet approved, so that's why it's probably a little bit lower. Okay, so very good. So just a slight advantage to Darapomdex. And our second question is, assuming you have access again to all therapies, what is your preferred treatment option for triple class refractory disease in a patient who has truly progressed on all 5 major drugs of bortezomib, carfilzomib, lenalidomide, pomalidomide, and daratumumab. So the true penta-refractory patient or triple-class refractory patient. Would you give them selinexor-dex, belantamab mafodotin, melphalan flufenamide, also known as the artist formerly known as melflufen, or some kind of combination therapy, as Philippe had mentioned, VDT PACE or something of that nature? Wow, we really have quite an overwhelming support today for belantamab mafodotin at about 85%. Excellent, that's great. So if we have our panel up, I'd be very interested in Nupur, why don't we start with you? What is your take on, going back to that first question, when you have a patient that's VRD, then lenalidomide maintenance, now relapsing for the first time, what's your go-to approach?
So, that's typically our patient population right now, Joe, as you've mentioned. Most of my patients, at least, will be on lenalidomide maintenance. So this is a len refractory patient population. And as Philippe has very nicely outlined, I think most of us go to a POM-based regimen, as do I. So POM-DARA seems to be the go-to regimen. Sometimes you do go by how the patient is progressing also. And, although there's phase 1 and 2 data with KPD, I do tend to use KPD also in this setting, depending on how the patient has progressed.
Great, thank you. I know that we really don't have a phase 3 of KPD, nor really are we expecting one, but I think our experience has pointed us there. Philippe, do you want to comment on that, just in light of, obviously, you couldn't put DPD in your highest recommendations because of the lack of phase 3 data yet, but do you foresee that changing?
Well, definitely yes. I guess that based on phase 2 study, and we have at least 2 that are already published, one in leukemia and one in blood, we can expect to have a very good PFS, roughly 20 months. That will be very close to what we can expect with KD DARA or KD zatuximab potentially. You are very lucky in the US to have access to combinations very easily, and this is very difficult in Europe, and Niels and Francesca may confirm that it is very difficult for us to use POMDEX DARA. I would like to use it, but I can't in my routine practice. So that's very difficult, and well, we are going to submit this paper, those recommendations, very soon, in fact, I hope in a very good journal. But next December, we will have Apollo available potentially, and we will need to update those data again and again. So that's not that simple.
I'm sure you will be excited to, again, write another paper with all of us giving you comments at all times of day or night. Francesca, maybe you can chime in, and then I'll ask you after Niels to chime in again on this early relapse, what your approach is now and what you think it will be when all of those options are available to you, including the isatuximab, carfilzomib, and daratumumab, carfilzomib. We just had approved here in the U.S. daratumumab and carfilzomib last week, and so we have access to that now too. But Francesca, what are you doing now, and what do you think you'll be doing in the near future?
Yeah, what we are doing now is what we can do based on approval and reimbursement. So basically, we can use pomalidomide. We will use pomalidomide and bortezomib, I think, as Philippe showed in the guidelines. Otherwise, to switch the drug class, we use carfilzomib, and we do not have at present the combination of the anti-CD38 plus POM or plus DARA. That, I believe, will definitely be the treatment of choice as soon as we will have these regimens available, because I was looking at the treatment flow that Philippe very nicely showed. It's clear to me that anti-CD38 will be used as soon as possible in the treatment of patients. So if they are not used upfront, they will be used at second line as soon as we can combine them with one drug that has proved to be effective in patients refractory to lenalidomide.
How about you, Neil? Same question. What are you doing right now? What do you think we'll be doing in the near future?
So I think we will hopefully we will be increasingly going to use upon approval and upon reimbursement, which is also taking a lot of time in Europe, carfilzomib-based and pomalidomide-based regimens. But currently we still use a lot of Velcade-based regimens. And one of those in daratumumab naive is DVD. And hopefully soon we will also be able to give POM Velcade dexamethasone to patients progressing on lenalidomide maintenance. And of course, in patients with a very long remission duration after transplant, we will discuss a second transplant if stem cells are still available. And in the United States, of course, you have to consider the first transplant if it was delayed.
Yes. Niels, just one quick question about your use of DVD when you use Dara, bortezomib, dex. Do you do it as per the original Castor study, or do you keep patients on bortezomib longer every other week, indefinitely until progression?
In high-risk patients, I continue Velcade until progression, as long as they tolerate it.
Okay. Nina, I have a question for you and the 58 postcards in your office, which looks fantastic, by the way. Nina, if you had a choice theoretically, Thanos mentioned in his lecture the difference between using, if you will, a next generation drug from the same class versus class switching. So you have someone progressing on lenalidomide. We've heard a lot about the desire to use a pomalidomide-based regimen. Is it more attractive for you to, let's say, go to daratumumab POM if a patient hasn't had Dara before? Or would you rather go to daratumumab carfilzomib? And similarly, Philippe, you can prepare. I'm going to ask you the same question, but I'm going to ask you if you have a preference between Dara and ISA in first relapse in someone who hasn't seen a CD38. But Nina, what sorry to use the word, what trumps in your mind the choice? Is it going to a different class, or is it going len to POM or len to CAR, essentially?
It's interesting because I think if I was just answering that question in a vacuum, I'd say it's best to switch classes when you can, because you really want to get to the myeloma cell that's become smarter, right? So you want to go at it from a different direction. That being said, I think the Dara-POM Dex answer that was so popular is because of the convenience of Dara and POM together, especially now that we have subcutaneous Dara and eventually the schedule goes to monthly. When you have an oral drug like POM, since there are good data to support that this actually works. Even, obviously it's been studying this in the third line after second relapse, but still we think that we can get good use out of it. It makes sense from a quality of life kind of ease standpoint to do that, although scientifically I'd rather switch classes.
And then Philippe, I'll turn to you for that question. I ask you, Niels, I'll have one question for you, and then we'll go to the wall to see if there are other questions. But Philippe, the question was, if you had a choice in your early relapse to go to a ISA or Dara-based approach, let's say with carfilzomib or POM, frankly, do you see a significant difference between the two?
Well, in fact, I would say that when comparing, for example, IKEMA and Candor with KD plus either isatuximab or daratumumab, the patient population was not exactly identical. The hazard ratio with favor is isatuximab, but we know that, I would say the efficacy is rather the same. And we know, for example, that we cannot salvage patient progressing on Dara with isatuximab. You are the PI of this study, and vice versa, in fact. I think that Dara will be more convenient, as mentioned by Nina, because of the sub-Q formulation, but isatuximab sub-Q is in development as well. The issue in Europe will be potentially very soon the cost, and we are going to use the drug that will be the cheapest, definitely, as soon as isatuximab will be available sub-Q.
Yeah, and you've stated it well. Our paper, of course, is submitted, so I won't reveal all the results. But yes, there isn't evidence thus far that we can overcome Dara resistance with ISA, which brings me to the question I want to ask Niels before we go to the wall, which is, Niels, I mean, you're one of really the world experts in understanding CD38 resistance. Indeed, Thanos mentioned it in his lecture as being something that we need to understand better. There is some evidence that we've been working on about giving people a CD38 break, as it were, for a minimum 3, if not 6 or even 9 months, and then potentially going back to it, whether it's back to the same DARA or switching to ESA or vice versa. I just wanted your thoughts on that, because I think this is something the IMWG has struggled with, and people are very interested in knowing about the potential of retreatment until we have actual studies that can show us where the benefits of retreatment are. But in your estimation, how do you view that CD38 resistance and potential retreatment?
I think an important study is ongoing, looking at the value of KD or DARA KD in patients with previous exposure to daratumumab, but with a daratumumab-free period of at least 3 months. So from that study, we will learn whether 3 months or maybe a longer period of time is needed to regain the efficacy of daratumumab, because we need some time. We show that you need at least 3 to 4 months before CD38 goes up on the tumor cells, and you need 3 to 4 months before NK cells go up. So I think from that clinical study, we will learn a lot. On the other hand, we also know that daratumumab has also potentially very beneficial effects on the immune system. So it eliminates immune suppressor cells. So maybe when you sequence daratumumab with another immunotherapy, or even continue daratumumab with that immunotherapy, then you do not need that washout. But I think we need more data from clinical studies to really get to know more about that.
Great. So I think we'll turn to the wall, or if I can, Patricia, maybe I can squeak in one last question to Nupur again about the role of selinexor, because we've seen a divide in the community around the use of selinexor, be it by itself or now potentially with bortezomib, as in the Boston study. When are you primarily using selinexor off study?
So, typically we're using it in the relapsed refractory, sort of the penta-refractory patient population, or the penta-exposed. I don't like to use the word penta-refractory, but certainly patients who've received pretty much everything. But I'm glad you mentioned the Boston study, Joe, because we are using, at least I in my practice am using it in combination, because I do use the weekly selinexor. It's much better tolerated, whether you use it in combination with bortezomib or with carfilzomib. Once it's done on a weekly regimen, it's much, much, much better tolerated. I tend to use either or proteasome inhibitor with the selinexor at either 60 or 80, and that seems to do its job. It's actually been used a lot now that we have all of these BCMA targeted treatments as a bridging therapy. It's something which is quite useful, especially in patients who've seen just about everything, and it's a good salvage also.
Great. Thank you for your comments on that. I think similarly, I've had the privilege of using it in many, many patients now, and I think I described it the other day as kind of like a Mack truck. It's very powerful and potent, but you have to know how to drive it. It does take careful supportive care, especially that first month or two. And we really have seen a dramatic improvement in its tolerability when given once weekly. So thank you for your comments. So Patricia, maybe we can turn to the wall and see if there are others who are interested in asking questions or making comments.
Yes, is there anyone at this time that would like to add anything? A question, a comment, please hit that raise your hand icon, and a blue bar will come up to indicate that you would like to join our conversation before we wrap up for the day. This is probably your final chance today before we regroup again tomorrow. So if you have a question, now is the time, or a comment.
So maybe I'll jump in and ask a question. Francesca, as I understand, in your situation, you're not currently having immediate access to neither belantamab nor selinexor. And if you had your triple class refractory patient tomorrow, why would you choose one over the other? We saw from the group that there was really quite an overwhelming support for belantamab over selinexor, but What would your take be on that?
Well, I have to say that now we have a compassionate program for belantamab, so we are starting to having this drug, and so we are currently using it in patients that are refractory to PI, immunomodulatory agent, and anti-CD38 monoclonal antibody. And I have to say that the experience, as well as the experience with clinical trials, is good in terms of tolerance, except for the what we know about the corneal events. And I like very much the discussion we had before on how to try to optimize the schedule of the drug to reduce the occurrence of severe events in an attempt to prolong the duration of response and the infusion. Regarding selinexor, this is not reimbursed, and it can be obtained with specific requests for patients. There is, as you said, a toxicity that could be significant, at least at the beginning of treatment, with the nausea and so on. So I think, as you said, it's very important to consider this toxicity and try to maximize with supportive therapy the tolerability. That could be an issue, even if the drug has the advantage of being oral.
Wonderful. And Nina, if I may, Brian, before you cut us off here, I think I have a quick question for Nina, which is, we've sort of pillaged you from the immune therapies section, because obviously you work closely with Tom and you lead a lot of these immune studies. If you were going to be a prophetess for a moment and look into the future and say, between CAR T, bispecifics, and belantamab, let's say, which of those three do you think will be the first in the first relapse market? Which of those three do you think will make it earlier on in that first relapse segment?
I think belantamab has the most likelihood of getting there, only because the ease of getting it is going to be, I think, better. It's going to be easier to get. Let's say you don't use it in the quite 4 treatments that it's on label, you can move it up a little bit, like we did with Darapom Dex. That's going to be impossible to do with a treatment like CAR T, which goes through so many levels of insurance approval, et cetera. You really have to dot your I's and cross your T's to get approval for that. So I think for logistics, it's going to be that, but I would really like to see how CAR Ts fare earlier in the course of myeloma disease.
Great, that's really helpful. I think I saw Brian appear, so I must bow to the boss. And I will turn it to you.
So Joe, this has been a great session, but so if you want to make some closing comments, and then if you want to turn it back, I think myself and Vincent will just make some comments about the session overall. So.
Sure. No, thanks. I won't keep us long. I think one comment, one question came in from Eloisa Riva regarding, high-risk disease. I think one of the themes that Philippe brought to us, and one of the themes that I think is just happening in myeloma, we've always had this tension between, are you in the cure camp or are you in the control camp? Were you previously in the Barlogi camp or the Rajkumar camp, as it were? And I think all of us feel that there isn't a perfect modality yet, but I do feel that we are tilting a little bit more to heavier therapies. Looking at this morning, whether it may be quadruplets up front and significant triplets at first relapse, that 1-2 punch, as I often call it, to patients really becomes important and prognostic in the long term, as opposed to saving the best for last, as it were. And I think our guidelines are reflecting that. The discussion was reflecting that. Based on what's available to you, it very much appears that we are being significantly more aggressive early on than even we were just a few years ago. But thanks so much, Brian. I'll turn it back to you and Vincent for concluding thoughts of the day. Great day. Thank you for including me.
So thanks, Joe, for chairing what was a wonderful session. And I'd just like to thank all of the participants from this first day. I think a wonderful day with very, very excellent presentations and very interactive discussions. And so really pleased that people set aside the time to be involved and to contribute their ideas or concerns or questions or input. So thanks to all of you. And I'll turn it over to Vincent before we turn it back to Patricia to officially close for the day. So Vincent.
Oh, thanks, Brian, and thanks again, everyone. This was a really great day one. We accomplished a lot. The meeting went extremely well. Thanks to every one of you and all of those who participated. We are sorry that we couldn't get to some of the questions on the chat box due to time constraints. We had to condense this meeting, which usually goes over a full day, into a short few hours because of the time differences. Please make sure you come tomorrow because we are going to honor people who won the Kyle Award as well as the Dury Award. And so we need to be there to give them support. And also for the working committee reports, we are going to call these working groups working committees. So there is the Smoldering Multiple Myeloma Committee, the Bone Disease Committee, Mass Spec Committee, and Immune Therapy Committee. These people have met many times before the actual summit to iron out the strategies and plans and proposals. So please be there for that. And then Philippe and I will do the algorithms as well. And Dr. Dury will talk about COVID-19 publication. And we'll have time for open discussion and questions. So again, look forward to a great day tomorrow. Please come, and over to you, Patricia.
Thank you. Well, we hope thoroughly enjoyed today's meeting. One more quick announcement before we wrap it up. We would love to get your feedback on today's program. So when you're ready to leave, please click the exit meeting button in the top right corner of your screen, and this will direct you to the survey. On behalf of the International Myeloma Foundation, I'm Patricia Stark. Thank you so much again for your participation, and have a great rest of your day, and we'll see you tomorrow.